On to scheduling. Our health system has several centralized scheduling departments, as well as an ambulatory electronic medical record. We have 3 electronic medical records in our system, none of which talk to each other, so you can imagine the challenges that poses. We worked with our schedulers to help them understand the importance of the inclusion and exclusion criteria, the importance of Medicare versus non-Medicare patients, and how to determine what study was needed. Is this patient calling for their initial screen? Are they calling to schedule a follow-up screen? Or are they calling to schedule a follow-up diagnostic study? Because those two, the initial screen and the follow-up screen, compared to the diagnostic study, have different scheduling codes. At the time, we were also very concerned with being sure that patients understood their payment options. Although now our program is no charge up front, we still need patients to understand that they may receive a bill if their insurance or if their Medicare coverage does not cover lung cancer screening, as some do not. We also needed to be sure that our schedulers understood that although we have approximately 23 scanners throughout our health system that can perform scans on outpatients, only 12 of them are actually performing lung cancer screening. Technologist education is key. We held meetings with the chief technologists from across our health system. We had to ensure that they can build the protocol in their scanner, do a phantom test, they understood the processes of scheduling and finance, the routing of the images, the post-processing, and then database management, as we do maintain a database of our own of all patients that are in our program. Keep in mind that we built our program long before CMS came out with their national coverage decision, and part of their NDC is that national registry participation. We will be participating in the national registry provided by the American College of Radiology, but we will continue to man our own database. Technologists also need to be fully aware of how to determine the follow-up exam and eligibility. Is the patient coming back for a future screening study versus a future diagnostic study? This is very important. We met with the referring physicians. We tried to get them to understand the NLST, the shared inclusion-exclusion criteria, and how the work of scheduling exams was going to happen. All exams in Ohio are required to have an order by a primary care physician. We did have a process set up, and we still do, for those patients who may not have a primary care physician who wish to have a lung cancer screening exam. We will find a primary care physician for them. Payment. We wanted to have the primary care physicians understand that although some insurers and Medicare have decided to cover this, most of them haven't quite figured out exactly how to do it. There are 2 arms to CMS. The decision-making arm that came out with a national coverage decision that was effective February 5th of 2015, and the arm of CMS that's actually going to implement that decision. And as you can imagine, the 2 don't jive up. So we have a decision to cover, but we do not have a process on how. We also discussed with the primary care physicians the fact about the radiation dose, and that although we strive to keep our doses as low as we can, and they're approximately 1 to 3 millisieverts, this is equal to about 3 years of natural background radiation. And this is a dose screen where you can see that our DLP in an average lung cancer screen patient is around 100.